Can you tell if people are filing in, Dr. Glassman?
It says there's 10 participants I see on this.
Okay, very good. Okay. Good morning, everyone. The program will begin shortly. We're waiting for more attendees to join us. Thank you for your patience. Good morning, everybody. We're just waiting for more participants to join us. In about a minute, we will get started. Good morning, everybody, again. We're waiting for a couple more people to join us, and we'll get momentarily started in about 2 minutes. Thank you, everybody who has joined us, waiting patiently to get started. We're just giving about another minute for people to join us and have a large crowd. They are running a little behind, but they will be with you momentarily. Thank you for your patience. Okay, welcome to the Lunch and Learn. The program will begin just in a few minutes. Thank you for joining us today for the Lunch and Learn. My name is Nancy Rios from the University of California, San Francisco School of Dentistry, and a member of COTAC as an administrative officer. I will be hosting today's presentation. We are happy to have a large crowd. I can see a good amount of people already joining us. First, we will have some housekeeping items. Dr. Glassman, thank you, sir. For logistic reasons, everyone is muted. We will ask you to please use the Q&A box to ask questions. You may formulate those questions during the presentation at any time, and they will be answered by our presenter today at the end of the meeting. We will allocate some time to answer as many questions as possible. The presentation will be recorded, and a copy of the video will be uploaded to the COTAC's website, accessible to all of you. Now, allow me to introduce to you our principal investigator, Dr. Steven Silverstein, Emeritus Professor at the University of California, San Francisco, and a diplomat at the American Board of Dental Public Health. Dr. Silverstein will do the honors to introduce our guest speaker of the day. Dr. Silverstein?
Thank you, Nancy, and thank you, Dr. Glassman, and all those attending this interesting webinar. For those of you that don't know, Dr. Paul Glassman is now the Associate Dean for Research and Community Engagement at the College of Dental Medicine at California North State University in Elk Grove, California. He's also a professor emeritus at the University of Pacific Art Dagoni School of Dentistry in San Francisco. He has served on many national panels, including the Institutes of Medicine Committee on Oral Health Access to Services that produced a IOM report, Improving Access to Oral Care for Vulnerable and Underserved Populations. Dr. Glassman is a proud graduate of the UCSF School of Dentistry. He spent many years at Mount Zion Hospital Dental Clinic, actively treating the oral health care for special needs populations. After the Mount Zion dental program closed and the hospital closed, he became a professor at the University of Pacific School of Dentistry, where he continued his activity promoting oral health for special needs population. Also at the dental school, many of you don't know the background that he was an advocate for the registered dental hygienist and alternate practice. His advocacy produced a workforce model, 1050 demonstration project for registered dental hygienists and alternate practice. And after a few years, that was able to be converted legislatively into a new dental workforce position for the state. He is also active in teledentistry, and part of that is using the workforce of the registered dental hygienist and alternate practice. At his new dental school in the California North State University, he also recently set up a training program for registered dental hygienists and alternate practice. And he recently told me that he had 275 hygienists enrolled in that class. This fall, College of Dental Medicine is planning to enroll its first dental class. So as Dr. Glassman moves on to Elk Grove, he also is developing, I call it the Glassman app. So I'll turn this over to Dr. Glassman to discuss his new project.
Great, thank you, Steve, and thank you for the embellished introduction. I appreciate that. And I appreciate the opportunity to be with all of you who are in attendance here. Of course, I wish that it was in person. It's certainly not the same talking to a computer screen and not being able to see who's smiling, nodding, or falling asleep. But hopefully you'll find the topic that we're going to talk about today interesting and more than that, useful for your work. So we'll move on to the title slide of the topic we're going to talk about, which is this one, which is improving oral health using early childhood oral health assessment system. So I'm going to talk to you a little bit about a system that we've been developed. Actually, I've been working on something like this for more than a decade in various iterations. So we'll give a little bit of a historical perspective and help you understand why we've done this and what it does, and then talk about the various phases and then where we are now with this kind of work. And I also want to put this in some context for the challenges that we have in producing oral healthy population, and how these kinds of things that I'm going to talk about today can help us to meet those challenges. So I'm going to start out with just a little bit of background, just some data. And I've stolen this data from Dr. Kumar's office and all the folks that were active in putting together the oral burden of disease report that Dr. Kumar's office put out. I actually noticed, and I remembered when I looked at it last night, that my name is listed as a contributor to it. So I was proud to be able to do that. But I think just to and I'm guessing that the next couple of minutes are going to be things that everyone on this call is pretty aware of, but just to make sure we're starting from the same page. So one of the pieces of data in that report is this one that's looking at comparing California with both the Healthy People 2020 goals and then also what the US norms are. And so one point to notice is this piece of data right here, which is dental caries experience in young children. You can see that the US target is 30%, the US baseline 33%, California 53%. So really way an outlier and not a good way in terms of number of very young children with dental caries experience. And the thing we're going to be talking about today is very much focused on young children. And I think this is, if you didn't need any other piece of data to understand why what we're going to talk about is really important, that one piece of data is that. And also even, when you get beyond just the 3 to 5 year olds or just beyond the dental caries experience and look at untreated decay, still not quite as dramatic, but still California in worse shape than the rest of the country. So you can sort of see these things from the report in a more graphical way, but it just sort of stands out how California is lagging behind the averages in the United States in these critical measures of disease. Also, it stands out when you look at some of the graphs in that report that this data is pretty skewed by race and ethnicity, that the white children are much less likely to have untreated caries than people from other groups. It also is pretty clear that it is different by income. So this is just using a proxy for income. Children in free lunch programs much more likely to have untreated decay than have a history of decay than children who are not in those programs as a proxy for income. And also just looking at sort of even precursor to being a 0 to 5 year old child, as somebody was pregnant before that. So looking at pregnant mothers' use of dental care, comparing people with private insurance, which is again a proxy for more affluent populations compared to the Medi-Cal populations, much less likely for the mother to have had any kind of prenatal dental visits. So, all of that leads to the conclusion that I think there's maybe one more, which is, again, this is just more directly related to income. All of that leads to the conclusion that we have a huge number of people skewed by race and ethnicity and lower income that are not getting adequate dental care services and having a larger amount of dental disease. So, one question, of course, that comes up, why is that? Why do these disparities exist? I think this is something that all of you live with every day, but I'm just interested actually in getting out on the table a few responses. So Nancy mentioned that we're going to have some time for Q&A at the end, but also I'm willing and actually going to ask at this moment to get some feedback from you. So this is going to be a little bit more interactive. So on your, somewhere on the, your computer screen is a Q&A function that you can open up a Q&A box. And so maybe if you could do that now and type into the Q&A box, just some quick, it doesn't have to be a paragraph, just 1 or 2 words about why do we see these huge disparities? Why do more affluent and white populations get dental care and have less dental disease, and such disparities between the sort of those who do and those who don't have good oral health. And so just type in a word or two, and let's see if we can get some. So historic racism is one thing that came up. Thank you for that. Lack of access to education, access to care, upstream social factors, race, health inequities. Don't have dental coverage and education, is threefold: Medi-Cal providers, not educated, cultural experiences. Yeah, no, thank you for that, and I think would probably list a lot more, but they would probably be all along the same theme of it's not that people who are low income or in diverse racial populations don't know about dental care or don't care about it, or don't know there's such a thing as a dentist. And so the reason I asked for this little exercise, just to state the obvious, is that I see a lot of conversation about this question of why people are not getting good oral health and dental care. And the conclusion often points to the idea that what we need to do is to get people into dental offices. That's the answer. We need to do a better job of screening and referral. We need to get physicians to make referrals to dentists. We need to get people into dental offices is sort of the premise. Well, I'm going to present to you a different idea. And this idea is going to underpin all the rest of what I'm going to say here, which is that I think we have an opportunity to fundamentally rethink that idea. And instead of thinking that the dental office is the center of the dental universe, and when I say center of the dental universe, I'm talking about the fact that when people think about getting good oral health, what they think about is I need to make an appointment and go to a dental office. So instead of thinking about the fact that the dental office is the center of the dental universe, I'm proposing that we think about the fact that the dental office is a sophisticated surgical suite where dentists are trained and equipped to do complicated things that require the office, they require the equipment, they require all the stuff that's there, but they're also hard to access for all the reasons you just all put in the Q&A box. They're hard to access for many people, and they are expensive to operate. And so to think about the fact that we're going to solve oral health problems by getting people into dental offices as our primary strategy, I think it's just not a winning proposition. So I'm going to frame the idea that I think we have the path forward is around three things. We're going to focus really on one of them today, but I want to just lay the other ones out here, which is the path forward is these three things. It's rethinking how do we pay for health services in general, but in today's conversation, particularly oral health services. And so there's some movement already in that arena about thinking of different ways of paying. People refer to it as value-based care or value-based incentives, paying for oral health outcomes as opposed to just paying for procedures for people to do things. That's probably going to happen fairly slowly by the looks of it. So, but hopefully in the future, there will be more progress on changing the incentives. So providers and health systems are more concerned about producing better health outcomes than they are just about doing lots of stuff, which is the current major incentive. We also have now some fabulous new prevention and behavior science, things that just did not exist when I was in dental school. Just fully all the understanding about silver diamine fluoride and the ability to seal caries and the effect of sealants and the ability to place interim therapeutic restorations. All these things can be done without local anesthetic shots, without drills, without dentists, can be done in a community environment. All that prevention and behavior science, which we can bring to bear now on community delivered care, and really allow us to make the switch to the idea of the dental office being the center of the dental universe, to thinking about a community engaged dental care system. And I'll come back to that, community engaged dental care system being the center of the dental universe going forward. So let me just move on and think about some conclusions from all of that, and some conclusions for particularly now focusing on the disparities in both health and access of 3 to 5 year olds. So in contemplating this really a decade ago, came to several conclusions. One is what we've just said, that dental care is just too difficult to access for many families of young children. And I want to add to that, what should it say is dental care in dental offices is too difficult for many people to access. The problem is not that they don't know about dentists, and the corollary of that, the solution is not efforts to get people into dental offices. But really the important thing on this slide is the idea that that there are, even in efforts to try to get people into dental offices, there's just not enough case management and care navigation resources out there to be able to do an effective job. Even those systems that have tried to do that. I think you've heard about some of these on this recurring series of webinars, even though someone tried to get quickly overwhelmed by the need. If you're trying to get everyone that you come across, screening and referral systems, however they're shaped, if you try to get everyone into a dental office, you're going to be very unsuccessful because the need for case management and support in doing that is just overwhelmed by the need. So we came up with a strategy, which was try to use a workforce that's already in contact with families of young children, figure out how we could use that workforce to effectively address this problem. So now I'm talking about community health workers, home visitors, potentially others, but we'll just refer to those two categories. And so the idea was to train and support them to do several things. First of all, to act as a first level of triage, to be able to figure out which are the families where they're really doing okay. You know, there's actually not a problem at a very young age versus the families where, you know, they really do need some help, or they really got urgent issues. They really need a lot of help. So our premise was that we could use community health workers and home visitors as that first level of triage. And I'll give you some data and methodology about how that worked out in a few minutes. That they could perform the triage, they could provide information to families, and they could be an effective way of supporting the adoption of mouth healthy habits. I don't know if there's any pediatric dentists on the call today, but, and so I hope you'll be open to what I'm about to say, which is that I disagree with the very often quoted idea that you hear from the American Academy of Pediatrics and the Academy of Pediatric Dentistry about the age 1 dental visit. That almost sounds like heresy in the world of dental care, because that's such a common idea now. It's been promoted so effectively that every child needs to have an age 1 dental visit. And when I talk to my pediatric dentistry colleagues, what I get is that the primary reason for that visit is to talk to parents. It's the conversation that's critical during that age 1 visit. The term interceptive guidance is used to understand what their habits are, what they're doing at home, counsel them about how those bad habits might lead to disease, what different habits they could substitute, understand their concerns. It's all really the conversation that's the basis of that. And so I'm maintaining here, and in the system I can tell you about, that conversation can take place, at least a lot of it, and it can take place fairly effectively, translated through community health workers and home visitors. It does not take a dentist to have that conversation. Now, again, this may be heresy for some people. I'll provide some data to you about how community health workers and home visitors can actually play an effective role in that in that system. All right, so adopting that as a strategy and then thinking about the benefits of that. Our idea when we first started was that if we could train and adequately support and equip home visitors and community health workers, that we could do then a better job of reaching the population that's pretty much outside the dental care system now and be able to better identify risks for dental disease, that we could support behavior change. And I didn't include a bunch of slides that I have in other presentations in this slide deck about the basic principles of behavior change, but one of them is messages delivered by trusted members of one's own community are much more likely to get acted on than messages delivered by a dental professional. Now that seems counterintuitive to some people. And I know in my former and about to start up dental school, dental students and hygiene students are really trained to give what I call the speech. The speech is all the stuff that we know about how to prevent dental disease and everything else. It's not a good environment for us to do it. People are often in an office where they're nervous. They don't like being there. They're not really paying attention to what we're saying. We typically give them too much information and they can't really remember what we said. And so to have someone who is seen as a trusted member of their community, which community health workers and home visitors are more likely to be, someone who's in more regular contact with a person who can do what I call incremental behavior support, where instead of telling them 12 different things, you just talk about one thing. You know, why don't you try, you're putting milk, you know, in the bed, in the bottle when you put the child to sleep at night, and that milk has sugar in it and it can actually lead to the decay process. Why don't you try diluting the bottle a little bit? You know, just try putting a third of it in with, or a quarter of it, or a tenth of it in with some water tonight, see what happens. Then, next thing, how did that go? And well, yeah, it seemed to go okay. Well, why don't you try a little bit more? So that's the idea of incremental, small behavior changes, and support for that is much more likely to result in behavior change than any kind of speech that a hygienist or a dentist is going to give that's not in regular contact with a person. All right, so anyway, the benefits would be identification of disease, support for behavior change, and then this first level of triage, so that the always scarce case management resources can be focused on those who really need that case management to get into a dental office, where many children and families actually don't need that. And we'll talk a little bit more about how we differentiate those. Okay, so that was the design, the strategy, and the benefits that we saw. The first time we did this was back in 2010, so more than a decade ago. And this was with a program called Early Start. Early Start sounds a lot like Head Start, but it's not. It's a slightly different program. Okay, it's a slightly different program run by the Department of Developmental Services. And this is a program that tries to identify young children that are at risk for having a developmental disability. And one of the impetuses for doing this is, once children are identified as having a developmental disability and they're in the regional center system, they're in it for life. There's no, you come in for a few years and then you get out. So it's hugely expensive. And so if some children with who are at risk can get some extra services before they're at the age where they're determined to be in the regional center system, if they can get some extra services to put them on the healthy side of that, that's a huge, it's a huge benefit for both money and scarce services, et cetera. So we found that in that program, they were doing a lot of screening of families and asking them a lot of questions, and they really weren't doing much about oral health. So we were able to do a pilot where we added some oral health questions to what the intake workers were doing. And then that led to the same kind of things we just talked about, a triage, sorting out who might need what kind of services, and then getting into the right services, all as a part of this Early Start program. And then a few years later, we did the same thing. This was in a Head Start program. And this was one, we did this pilot at a Head Start program in San Mateo County. And it was in conjunction with a community health center. And it was a different program, but exactly the same idea. We wanted to use the home visitors in that program to add a few additional questions about oral health to the questions that they were already asking, and therefore be able to identify who's at risk, and then decide which children actually needed a little bit more help or a lot more help, and then connect them with the ongoing services that the health center was already provided. And that included in the clinic services, and it also included this virtual dental home system, which I'll come back and touch on in a few minutes. But again, the idea was very much the same. The home visitors were on the front line of engaging with the families and helping to both determine who needed more and provide first level education. So in preparation for this program, we did a lot of training of the home visitors. So I'll just show you a few things about the subjects that they were trained on, so that they could at least have a basic understanding of what caries was, what early childhood caries was, some of the consequences of untreated dental disease, so they could pass that information on to the families they were talking to. We wanted to make sure that they understood how to pass on families' recognition of what decay looked like. This is just a slide showing white spot lesions, making sure they understand about the use of fluoride, both the importance of it and how much fluoride do you use and how do you toothbrushing techniques. So if the home visitors were going to pass that information on, of course they needed to understand it. So that was part of the training program. We also wanted them to understand the issues around sort of the new science that's involved, that I mentioned a few minutes ago, the science of remineralization and caries arresting medication and sealing caries. Understand that we have these new tools available, fluoride varnish and silver diamine fluoride, and those of course have to be applied by a dental professional, but we wanted the home visitors to understand that and to understand the role of it, so when they start to make decisions about what happens next, they know those are possibilities. And we wanted to have them, of course, understand the tools. And so when we first did this, both in 2010 and 2014, these were all paper tools. And the paper tools consisted of some assessment forms and some informational brochures. And so I'm going to walk you through now without going through great detail, but some of the assessment system we had. So this is the sort of the beginning of the assessment tool. And you can see this is just basic demographics and gathering information about insurance. And then there was a section about oral health questions. And that's the orange section. And it's in orange for a particular reason, which I'll show you in a minute. But we color-coded these questions so that we have our brochure is also color-coded. And if there were some issues that came up around the stuff in orange on the questionnaire, then the home visitor would be alerted to refer to the orange part of the brochure. So it was sort of easy for them to make that transition. But these are all questions about things that those in the oral health world would understand, just about understanding, have they been having any kind of dental care? Are they having any problems that you know about? I'll blow up the bottom part of it. Does the parent any concerns that they have? Are they seeing any white or brown spots on the child's teeth? So these are all sort of oral history questions. And then of course, the brochure is color-coded with some responses to those things so that the home visitor right at the time of the visit could hand the parent the brochure. They could check some of those little boxes. So you don't tell them, read this whole thing, because they won't read any of it. Most people wouldn't. But to say, here's the two things that apply to what you just asked. So, I'm leaving this behind as a reminder of what we talked about today, so that they could focus on just a couple issues at a time and not be overwhelmed. Here's another page of the brochure that was looking at just some techniques for parents to recognize disease, even instructing parents how to sort of lift the lip. A lot of parents don't even know what their children's teeth look like because they don't really lift up the lip and look at the areas at the top of the teeth. So just that sort of basic technique. And then there's some areas about feeding. And so, are they putting the child to bed with a sippy cup, or is the child walking around all day with something that's got sugar in it, like juice or milk? The common myth out there that juice is good for your child. So to have your child walk around all day with a sippy cup with juice in it and not realizing how acidic and sugary the orange juice is. And so again, this is alerting the home visitor to provide some information and to be able to focus on that issue. Asking about medications they're taking. Or they have any habits like, dipping a pacifier in something sweet? That's a cultural thing that some cultures do. Are they taking any medications that maybe they're being administering the medication in a liquid syrup, which is loaded with sugar? They make it very sweet in order to hide the taste of the medication. So parents need to know if that comes up, then that's the opportunity for the home visitor to say, that stuff is very sugary, and you want to be sure and rinse your child's mouth out after you do that, because you don't want that sugar the sticky syrup can sit on the child's teeth. So some really sort of small interventions like that can actually be something that's totally within the purview of a home visitor to do, armed with this training and the ability to to convey this. We also teach the home visitors how to ask questions about cleaning teeth, what kind of toothpaste are they using, how much are they using, and again, all this stuff in the brochure. And then to train them how to do a visual examination. Now, we're not trying to turn them into dentists, but to be able, at least the home visitor, and maybe in conjunction with the parent, to recognize some obvious signs of dental problems that are going on. Again, teaching them about the potentially using a knee to knee method, or at least lift to do that. And I apologize for the pauses to get a little bit of water and clear my throat, but this is my fourth meeting of the day, and I've been talking a lot already. So I'm hoping my voice is going to hold out until the end. Tools, which are the assessment form, the training, and then at the end of that, they're producing a summary of what they find, and more importantly, they're making a risk categorization. Now, some of the dental folks, when you think about risk categories, you think about Canberra, and this is not Canberra. This is a very different kind of risk. We even thought about changing the name so we wouldn't use the word risk, so that people don't get confused about Canberra risk and this kind of risk, but we didn't. We're still using the word risk because we're talking about what puts someone at risk for dental disease. And so if you look at this, we're saying we have three categories: low risk, moderate, and high risk. And our definitions of risk here are that low risk is a family that's already following good good practices, both in diet and brushing and all the other things that they're being asked about. They give, let's say, the right answers, but they're doing the things that would particularly lead to good oral health of the children. And there was no abnormalities that were exist, no white spot lesions, no brown spots, nothing that looked looked like it could be a problem. So that's low risk. And so what you would do about that was you would follow up at the next visit. The next time you see that family, again, ask them how it's going, maybe repeat some of these questions, make sure things are still on track. But that's not a family where you want to focus your scarce case management resources on. So the next category would be someone in moderate risk. So maybe there was some things that they were doing that could lead to disease, but, and this is a judgment call, the home visitor decides that after they had a chance to provide some information, the family seems to get it. Oh, I didn't really realize that. Okay, yes, we'll definitely do better about that. Or I see I'm putting on too much toothpaste on the toothbrush. Thanks for the information about the smear. And they identify the issue and they talk about it. Family seems to get it. Seems pretty predictable that they're going to do what's needed to be done. Maybe that person doesn't need any more than, again, another follow-up at the next visit, depending on how long away the visit is, just to check and see how those things are going. Obviously, the high risk are people who have some practices that could lead to disease. But even after being provided with some information by the home visitor still doesn't think that's enough. Either the parent doesn't seem to get it, or they don't really seem like they're actually going to do it, or there's identified, they're looking, there's already a big hole in a tooth, which clearly needs to have a visit to a dentist. Something is different. So the high risk people need to have some further intervention by an oral health professional. Now that's important that I said oral health professional, not necessarily dentist, because it doesn't necessarily need to be a dentist. So the next part of the form is the recommendations. So it could be counseling, it could be fluoride applications, and as some of you know, people can be allowed, even the parent can apply fluoride. So it could be that a fluoride varnish, if they're in a program where they're properly trained to do it, it's supervised by a dentist. So it could be that we actually enlist the parents in providing fluoride varnish on a single dose administration that's given to them periodically. Or it could be that you're going to make a referral to someone. And so we have lots of things there in the referrals for nutrition counseling, specialty care, behavioral services, dental care. But dental care, again, doesn't mean necessarily a dental office. What it means is some dental professional. And so if there's a way that you have working in a program where there's a dental hygienist who might be able to intervene and help with either further triage or screening or provide some more information to the family, and there's a way to connect that hygienist with the family, that might be the next step. And would certainly be a preferable step rather than the visit to the office, which would be a lot more complicated for the family. But if there's a need for a visit to an office, then that might be the next thing that they do. So what we found in really the first project and the second one was fairly consistent. Numbers weren't exactly the same, but fairly consistent. And I think very interesting to me was that about 50% of the families we were dealing with, remember, these are low income, racially and ethnically diverse families, the people that would be predictably having the greatest amount of dental disease. About 50% of those families were found to be at lower or moderate risk. That either everything was fine with what they were doing, or with a little bit of information, it was judged that it could be fine. About a quarter of the families were determined that they needed some further educational assessment services or something, either education or assessment service from a dental professional. And in this particular pilot, they were using a virtual dental home system, so they could connect them to that virtual dental home system and then get them counseling or additional assessment by the hygienist. And then about a quarter of the families were deemed as needing a visit with a dentist. But if you think about those numbers, it's really a phenomenal difference from a system where everyone gets screened and referred to a dentist. And now you're talking about using your scarce case management resources on the 25% of families who really need that visit with the dentist. And the others are either getting what they need from the home visitor, or getting another level of help from maybe a hygienist or a virtual dental home system. So it's a much more effective way to utilize the scarce resources of dentists rather than referring everyone to go see a dentist. So at this point, I want to talk about a project that came up during the Dental Transformation Initiative. But if we could stop here for a moment and have you put stuff in the Q&A box, just any sort of thoughts or questions you have at this point. And I'm going to grab a drink of water while you're doing that. All right, so here's what it says. Wow, I appreciate the concept dental office as a sophisticated surgical office because it makes a lot of sense as it relates to historic systemic racism. Black and Hispanic people often without Medicaid treatment because of providers' assumption about who they are or their health behaviors. Yes, I think that's a great addition to what I had said because I didn't really touch on that so much, but it just is another reason to think about the fact that everyone doesn't need to go to the dental office. The dental office has a very important role, but this sort of primary information giving and triage, it may not be the only place where that can happen. I think there's another one here, sustainability for community health workers, right? So that's the question about us, and another one about funding. Thank you, Dr. Walton Hayes, for both of those. So that, of course, is the really important question: is how does something like this get paid for? So currently we don't have generally available payment mechanisms to pay for this kind of thing, but we don't have mechanisms to pay for it if it's a program you start from scratch. But we have lots of programs in the California now that already have these people. They already have funding streams, are already employed. So there are many community health workers that are working in some kind of program. We have lots of programs that use home visitors. And so what we're doing, and I'll get to that in a minute in our next iteration, what we're doing is using already existing, already employed workforce to use this concept. So we're not having to come up with new salary dollars. What we're trying to do is add on some oral health questions to the conversations that we're already having with parents. So it's not a whole new separate system from what's already going on. And that's where the funding can come from. Now, granted, there may not, every person in need may not be connected to a community health worker or home visiting program, but there are lots of people, and it's a great place to start without having to come up with a bunch of funding to be able to do that kind of stuff. Another question, this makes perfect sense. We're working with family resource centers, deliver health materials to their clients, another possible resource. Yes, family, any place where there's somebody, some non-dental person who's engaged with the family on a regular basis. So home visitors, of course, are typically going out to the home, but if there's a family resource center where people are coming in on a regular basis and someone there can be trained to do the same kind of screening and assessment and information and triage, absolutely, that's a great place to do it. Another one, the early age visits, first tooth, first birthday, are for the child to be acculturated to going to a dentist. That's why we press it here. Sure, I get the idea that coming into a dental office and having that do it in a non-threatening way is a good idea, but there's other ways to do that. I'm going to touch on this virtual dental home system in a few minutes, which is a companion to this. And we have found that having a hygienist with a portable chair in a Head Start center or any other kind of place where the family might be going does exactly the same thing, that the children who've actually had a chance to sit in a little chair in a Head Start center and had someone with gloves and a mask and all the paraphernalia we now have to have and a light in their eyes, they come in just as desensitized to the dental office if they ever need to go there as the child who had that first visit. So I appreciate the comment, but I also want to put out there there's other ways of having that kind of desensitization to the office environment that don't necessarily require a trip to the dental office. Another comment, we're looking to partner with our other chronic disease programs. They had some oral health questions. Well, again, exactly the kind of thing that we could talk about that this fits into. And using other workforce is not as easy it sounds. They don't want to do it as it represents a lot of extra work for them. Oh, perfect question. I'm glad whoever posted that said that, because we certainly did run into that when we started the two projects I just told you about. We had a lot of comments that this is just more work. We've already got too much work to do. It's going to take a long time. We were able to actually get through that, not 100%, but I'd say pretty successfully, to get to people to realize that it's actually not a lot of extra work. We were talking about maybe another 3 or 4 minutes once they got used to it in the questions they were already asking and in the responses that they were giving. It didn't add a lot of time to the typical home visit, and it had huge amounts of benefits. The home visitors actually, once they got the idea, began to feel better about the services they were providing to the families. And so eventually they just became more acceptable to them that it was part of their job. Who's going to pay for that hygienist? Well, again, that's a complicated question, which I probably don't have time to go into now, but I do have some thoughts about it. But certainly if there's any kind of a program where hygienists are able to do something similar to the virtual dental home, where they're in the community and getting paid for those interactions, you can connect people in this kind of system with that. That's a way to do that. All right, well, thank you so much for all the stuff you've been posting. I want to just move on a little bit here to talk about where we're going more recently. So I'll give you a little historical perspective so far. So let's move on to the Dental Transformation Initiative. As you know, the domain for it was the local dental pilot projects. And there were 15 awards made. They didn't all actually get off the ground. So I'm not sure exactly what the final count was, how many local pilot projects actually took place. It was less than the 15, but we were involved with 4 of them. And in one particular one, the one that was with the first 5 in Riverside, San Bernardino, we developed a next extension of this early childhood assessment program. And we called it Early Childhood Oral Health Assessment, which is ACOA, is the nickname for it, ACOA. So ACOA for home visitors was a program we developed through First 5. And so the objective was to take the paper-based system that I described to you earlier and upgrade it to a technology-based system, to engage community health workers, and it was more community health workers than home visitors at that point, but that's actually shifting now, and then be able to connect those people who were identified as needing some dental professional help. Again, most, probably predictably, half of the families wouldn't, but those who did need that, connect them to the virtual dental home systems or the other community-based systems that were also part of the Dental Transformation Initiative going forward. So that was what we were trying to accomplish. We did take the paper questionnaire and turn them into an app that they could carry around on a little tablet. So all the questions were there. There was pop-up information. So if they said something about white or brown spots, they were able to pull up some pictures that actually opens up to a full screen, a little counseling system. All that was built into the app. And if you want to find out more about that, there's a link, I think, it was prior to the webinar, and I think that it's going to be put in the chat again in today's session, to this page on our California North State University website, which is about the local dental pilot project, the ones that we were involved in. And it's got information about a symposium we just had in the end of December on community engaged oral health systems. And there's recorded presentations, all the presentations that were made. And then there's all these links to various reports. And then one of the links is to a summary of this early childhood oral health assessment program in the Inland Empire, how that came from pilot to a healthcare systems integration. So I would urge you to, if you're interested in this topic, to read more about the results of that. A little bit of just kind of how it worked. That we had community health workers and home visitors engaging people in a whole bunch of different kind of places. So some people have already put some creative things into the Q&A box just now, family resource centers, and here's places, even churches, elementary schools. We used a sort of a flip chart that's available from it's actually a PDF file, but we turned it into a flip chart from Boston Children's Hospital. It's I love it. I think they did a fabulous job of putting together sort of basic education material. It's got a lot of pages into it. So we trained the home visitor, don't try and go through this whole thing, to be just to target the particular issue that you're finding. And maybe on this particular in conversation, you're only gonna show them one page, because there's lots of pages in here. There's stuff about what cavities look like, how they progress. There's stuff about how things get out of hand. There's stuff in here about sugar and drinks, why there's so much sugar in drinks. There's way of looking at, this is very visually striking, the number of spoonfuls of sugar that you would have in a can of Coca-Cola, for example. But even something you think might be an 8-ounce box of juice, how many spoonfuls of sugar are in that? So they have great materials about that kind of stuff. They have stuff about sippy cups. They have things about toothbrushing. So all those educational materials the home visitors and the community health workers are armed with, so that they can provide that education and counseling once they identify the issues that are for that family, and fluoride toothpaste. And so at the end, what we found was it's not quite the same numbers, but it generally, if below the surface, it generally breaks down to our previous findings that about half the families were low risk. again, we said 50% before, 46%, basically the same response. That about half the families, either they're already doing the right stuff, or with some counseling, a little bit of counseling from the home visitor or the community health worker, they felt confident they were going to do the right stuff. The medium is actually broken into that same thing, that they felt like they weren't really in such great shape, but or maybe they were doing some things that were not so good, but they seemed to get it. Or some of the people in medium category, now we really need to get a hygienist involved. And then of course, what's really interesting is that the people at the highest risk category, the people who clearly had disease that needed attention, only 12%. We had come up with 25% previously. This is 12. Again, I think the take, without worrying about the details of numbers, the takeaway here is that a community visitor, community health worker, home visitor can act as an effective front end to a dental care system and effectively triage and help to sort out who really needs to be seen by the dental professional, where many people don't. So you can use your scarce case management resources on just those people who need that kind of intervention. So they're doing this in this is an outside tent in Head Start. So you look at the creative costume. That's the Tooth Fairy costume that one of the community home visitors was wearing. Again, a health fair. As you can see, their work hasn't stopped during the COVID era. They're masked up here, but still doing the same kind of conversations with families. I want to mention very quickly that we tried in this particular, we had the opportunity, it may not exist everywhere, but we tried to connect the system to a virtual dental home, which is a part of the big picture. Again, I want to bring back this idea of community engaged oral health systems, thinking about how do you organize the community around the various activities that can take place by non-dental professionals, dental professionals in a community site, reserving the dental office for the most complicated dental procedures. And so the virtual dental home, if you're not familiar, I'm going to do this very quickly, so I apologize, it'll be quickly, but it's an idea where there's a hygienist and an assistant using portable equipment. They're out in any kind of place, school, Head Start center, community center, could be a family resource center, and now they're elevating. They're not just asking questions because it's a hygienist. They're actually able to collect records like x-rays and photographs and have a full dental record system, have a dentist who's able to review those records and make a decision about what ought to happen. And they're able to do things like place silver diamine fluoride or interim therapeutic restorations. So you can take this tooth with a small hole in it with no drilling and no anesthetic and actually place what's called an interim therapeutic restoration and stop that filling, that decay from progressing. And we know that system has the ability to keep 2/3 of children healthy without needing to go to an office. And that was before we had silver diamine fluoride. So now we're estimating about 80–85% of children can be kept healthy in the community. Again, this is just a radically different idea than the idea that all dental care needs to happen in a dental office. And I don't want anybody to walk away from here thinking I'm saying we don't need dental offices. I'm not saying that at all. But I think that the dental office is a very important part of the system, but it doesn't have to be the place where everything happens. All right, so now all that stuff is really, again, getting around the idea of we can really move now our thinking to the idea of community engaged oral health systems, where a lot of stuff can happen by non-dental professionals in the community, not having to start a whole new program, but actually leveraging existing programs. I totally agree with the person who wrote the comment before about they're not necessarily asking for more work, but our experience is it's possible to get past that and get them engaged in this kind of system. They do actually feel good about it after they're engaged in it because they feel like they're really providing better services for the clients they're serving. And so it's possible to get this kind of system engaged into an existing workforce that's already out there. So what we're doing now, after the dental transformation initiative was over, our next steps, we realized we had to actually go in a little different direction. The app that was made with the dental transformation initiative, the way the contracting was set up, that company was no longer going to support the app. The back-end database that held the data, they were not going to support that anymore. And so it really wasn't going to be available long-term. And we had to think of something different. So we've been now, our plan now, our current activity is we're partnering with a company that can maintain the application and the data. That's really critical. If we're going to have this thing that's going to be useful going forward and be available throughout the state, it has to be something that's where there's somebody who's got the responsibility of maintaining the technology and the data. And that we want to develop are developing a updated training and support system so that whether it's a home visitor, a community health worker, or someone who works in a family resource center, that we have both on demand on a website training materials, and also the ability of live session and support and technical assistance to help people get up and running with that. We've been doing it for now close more than a decade, as you've heard, and we think we can be very helpful in helping people put a system like this into place. And then the plan is to make it available statewide. So right now we're working with this company called Social Solutions. They have I think I just jumped a few slides here. Yeah, Social Solutions. They have a product called Apricot 360. I was told by the people from the company that Apricot 360 is in use in every county in California. It's not in use for oral health. Sometimes they're working with the Department of Corrections. So they have a lot of things. They have case management, other kinds of systems in it, but it's sort of a pretty robust case management, data collection, ongoing support system. And so they are actually in the process now, or you can see this is just some testimonials from what's going on in First 5 Riverside, where we're working with them about quote, Apricot is the connective tissue between all our initiatives. We're lucky to have met with Social Solutions, makes our lives a lot easier. And they're doing it with multi-model home visiting, family resource centers, internal programs, contractor management. So we're working with them now through the sort of an additional tail on our dental transformation initiative and the First 5 commission in Riverside to add on all the questions. Basically everything that I showed you before is now going to be part of, it's going to be a module in Apricot 360, so that that we'll be able to, again, ask the questions, pop up responses, links to educational resources. It's all built into the Apricot 360. If you're in a county where you're already using Apricot 360, they're just going to add this in and there won't be any additional charge to you. If you haven't been using it, I'm not in a position to give you full pricing, but it sounded like it was fairly affordable for counties to do this if you're not already using them for something else, to be able to incorporate this in the kind of work you're doing. Really, they're talking about if you have any number of families that might apply to, we're talking about really pennies per family. So right now that's what's going on. We're working with Apricot 360. That work's pretty much done now. They've incorporated all the questions. We're now working on connecting the educational resources to it. So that work is coming along. And our timeline is this. So right now, spring 2021, we're converting from the Dental Transformation Initiative application to the Apricot 360 version. We're developing and connecting all the associated educational resources, and then we're developing the on-demand and live supplemental training. That'll all be a part of it, and we plan on testing all that over the next few months. We're going to be having various people, try out various parts of it. And then this summer, we're going to start a full-fledged pilot. We're going to have a whole bunch of home visiting agencies that are going to be participating, and they're going to be using this in their processes. And so that they get some feedback, we're going to refine the materials. And then our plan is that by the fall of this year, we're going to have sort of updated version. This will be tested, modified based on the tests, and figure out what's working and what's not working, and make it all be working. Make this available statewide. So I'm sorry if you're from a county where you're looking at this presentation and saying, I want that, I want it today. It's a little bit like going to a movie, and when we used to go to movie theaters back in the old times, and you see the coming attractions and you think, oh, that's a great movie, I want to see that. And it says, coming in 2024. So sorry, this isn't exactly available right today, but we're hoping that it will be available statewide. We would really love to stay in touch with you though, if you're interested in this. I'll have my contact information back up in a minute. And we'd love to begin conversations with you if you're interested about how we can support you in your counties in doing this. So I want to just end the presentation by just going back to the idea of where we need to go in the future is really around these three things. We've got to continue to push for making rewards to providers that are based on producing better health, and better health of the community, not just better health of the people who walk into a particular clinic, but better community health. And we've got to think about how do we apply all the fabulous prevention and behavior science that we now know, and then all that through a delivery system where the center of the dental universe is not necessarily the dental office, but it's community engaged dental care system, because I think that is really the thinking that we have to adopt going forward. That oral health, we're going to do a lot better job if we can think about these as community systems, rather than think about getting everyone into the surgical suite, which is the dental office. So that was the end of what I had to present. I'm very interested in having further conversation with you. So I think given the way this is set up, that's probably going to be through the Q&A box. So if you will, at this point, put in any questions, thoughts, comments. I'm very interested in hearing what you think about all this, the viability of it. I think you might want to be involved in something like this in the future. Questions, go ahead and type things into the Q&A box. So can we get an electronic copy of the Boston flip chart? Yes, it is actually available for free. And I will get the organizers of this webinar the link address to it. You might be able to even find it by on their website. It's if you just search Boston Children's Hospital risk-based disease prevention and management of early childhood caries, that's a lot of words, but you could probably find it. But if you don't find it yourself, I will get a link to where you actually be able to download that. Fantastic presentation. Thank you. Grateful for information. Definitely interested in pursuing in the future. Yeah, please contact me if you are. Finally, something that could make sense for our small community. Thank you. Yes, we're really looking at the idea of, it's a slide I did not show in terms of our thinking about dental care delivery systems and virtual dental homes, the idea that you could actually take a rural, particularly rural, small rural communities where it just is not possible for dentists to open an office because predictably there's not enough population to keep them busy enough, but to have a dental office in that community that's connected by a hygienist who's over in the neighboring community, you know, one day a week or one day every other week, and then one over there, and then a home visitor program over here, and all those stuff that are doing the outreach and engaging families. And then some of those people need to come into the dental office. All of a sudden now you've got a community system where it's actually possible to have a viable dental office in that more rural community where you didn't before if everyone had to get into the dental office. So I think we have huge numbers of opportunities as we rethink this idea of the center of the dental universe and start to think about community engaged dental care systems. Let's see, any other comments? I don't see anything else here at the moment. Give you another, get a drink of water and see if there's anybody else who wants to post anything. Well, I don't see any other posts, so if something comes in the next couple seconds as I'm wrapping up, we'll I'll read it out and say something about it. But if not, no, thank you all for your attention. Looks like some people have gotten some ideas out of this. I hope most of you have. And as you can hear from my excitement in having the opportunity to present this and my gratitude for having that opportunity, that I really think this is the future of oral health, is really thinking about community engaged systems and being able to reach people more widely and integrating. Here you're talking about, a lot of people talk about integrating oral health into other systems. They tend to talk about medical dental integration is the phrase you often use. So it's integrating what dentists do with what physicians do. And you can hear in this presentation, I'm talking about integration in a much different way. I'm talking about, integrating oral health in with home visiting programs and community health worker programs and family resource centers. I think that's the kind of integration we need to be thinking about. And hopefully you can see there are some real and now tested ways of doing that we hope will lead to wider spread adoption as we go forward, and really be a benefit to everyone, a benefit to the population who needs better oral health and better care, more equitable oral health among the community, and actually better for both providers and then payers and the public health system as well. So I think at that point, seeing nothing else coming up in the Q&A, I will stop and see if Steve, if you want to add anything, or if not, turn it back to Nancy for some closing remarks.
Yeah, I was going to ask if Dr. Silverstein had any additional comments, or Dr. Kumar, or anybody who's in presence. Dr. Silverstein?
Yes, can you hear me?
Yes.
Very well.
Okay. Well, thank you, Paul. I think this system, which we talked about previously, be a boon to the state of California in that you have already investigated the possibility at very low cost that when you're finished with your pilot, you'll be able to roll this out to every county in California that has this system, this software system, which is a first. Presentations that we had are excellent software programs, but they've been limited to the county that has developed it. The other part is, I think, filtering down from your research showing that possibly only 25% of the young children really need to focus on the dental office, whereas 75% can be kept out of the dental office. I think those are the takeaway messages here. So I think that is a very important focus, that primary prevention should be done outside the dental office, and the $40,000 dental operatory should be saved for those children and adults that need to access that system. So we look forward to continuing conversation with you and updating us as you move along with your expanded DTI program, and keeping us informed about the development and rolling out of your app to other parts of the state. I guess when you get there, we would probably like a presentation from your software. Was that Apricot?
60, right?
Yeah, a presentation from them at some time.
Yeah,
when you get to the stage of how different local oral health programs could contact them as far as integrating it into their local program without huge costs. So
great.
I hope we don't have any more webinars the rest of the afternoon, that you can drink some hot tea and get your voice back.
Thank you for that. All right, Nancy, I'll go to that last then, unless Dr. Kumar is on and wants to say something.
I think he is, but he might be muted, so.
All right, we'll go on to your next, your slide then. So
Yeah, thank you so much. And there were no additional questions in the Q&A box. So if anybody has any additional questions, don't hesitate to email them even to me at nancy.rios@ucsf.edu. I'll be happy to make them available to Dr. Glassman for a more clinical and direct answer. On behalf of COTA, Dr. Glassman, thank you so much for your time, for this very informative presentation, for the generosity of your time as well, knowing how busy you are. And to all the participants and attendees, thank you for being present today with us. I also would like to thank you, Dr. Silverstein, for graciously being the moderator today. And we would like you to keep in mind that we will have another programming and a Lunch and Learn in an upcoming seminar very soon that we will be announcing. This concludes the Lunch and Learn for today. Thank you so much on behalf of COTA in the University of California, San Francisco School of Dentistry. Bye-bye.